G'day, welcome to Emergency Medicine Topics in one coffee. I'm Alan Giles, an emergency physician, and today we're going to take on the challenging area of child abuse. So let's start with the definition. This one's from Kemp and Heller in 1972, and I think would serve us pretty well. So, any child who receives non-accidental physical injury as the result of acts or omissions on the part of his parents or guardians, physical or psychological damage caused to the child by the abusive behaviour of others or the failure of others to protect the child from such damage. In fact, there's 4 types of interrelated child abuse. There's physical, emotional, there's sexual, and there's neglect. Today we're going to focus more on the physical side. In terms of increased risk factors, there's those related to the child and then those related to the family. From the child's point of view, well, they're an increased risk if they're a premature child, if they're less than 3 years of age, if they have developmental delay, chronic illness or behavioural problems, that increases their risk. From the family's point of view, well, you've got increased risk if you've got young parents or a single parent, if they're poor, if they're socially isolated, if there's domestic violence in the relationship, or if there is psychiatric illness in one or both of the parents. However, it's important to remember that you don't need these things to get child abuse. It can occur in just about any family dynamic. Let's think about the components of the history and examination of an injured child that presents to the emergency department that could make you suspicious of child abuse. We'll go from historical features. Well, has there been a delayed presentation? Is the examination and the history given sort of inconsistent? Were there no witnesses to the injury? How about what the relationship between the child and the parents are, or the parent? Is it sort of standoffish, or is it overly clingy? These sort of historical features should make you think, perhaps we could be seeing a case of child abuse. So now we'll go into some of the physical findings that you can see. Let's look at some of the physical findings that you might find in child abuse. When you first see the child, have a look at them. Do they appear unkempt? Do they appear undernourished? What's their weight like for their age? This may make you think about the possibility of neglect. Now what we'll do is have a look at some potential injuries you should look out for from the head to the toes. Now, let's start with the head. This is important. It's actually really important because in infants, this is the greatest cause of both morbidity and mortality, whether it be from direct trauma or from shaken baby syndrome. Now, if we just focus on shaken baby syndrome, where they're frustrated and shaking the child, these children can present with symptoms and signs that can be put down sometimes to a viral infection inappropriately. Things like a seizure, vomiting, irritability, decreased level of consciousness. When you're examining the child and you're looking out for those, look for any signs of abuse. Are there hematomas around their head? Look at the back of the eye for hemorrhages. Around the head also you might see lacerations, hematoma, and it may be inconsistent. If they say that the child has rolled off a change table at the age of 5 weeks, well, that's inconsistent with getting a hematoma because, well, babies don't really roll till close to 3 months. Other injuries you looked around the head, well, look at the ears, pulling the ears, and also look inside the mouth for damage to the frenulum from force feeding a bottle into the mouth. Okay, let's move on to the long bones. Now, if you shake a child, you cause shearing forces that can cause metaphyseal injuries. And remember, if you do an x-ray, you'll sometimes see callus formed, and the callus only takes 1 or 2 weeks to start being formed. Another general thing to remember is that the highest risk patients are those under the age of 12 months, and they tend to have multiple fractures. Now, let's think about other fractures we should be aware of. Under the age of 3 years, it's unusual to clavicle fracture. Certainly sternal fractures, rib fractures, especially posterior ones, because they crunch like this with a compliant chest. Spinous process fractures, they're obviously of concern. But also, when you do your general examination, make sure you check both arms, both legs completely. Examine the abdomen, examine their genitals, check their buttocks, check their back, because you don't want to miss anything. Just have a good, complete, detailed examination. Okay, let's have a quick chat about bruises. Bruises are quite uncommon in babies and pre-cruising toddlers. Under those circumstances, think about potential medical causes or child abuse. In toddlers, they tend to fall often, and they bruise over their prominences, like their elbows, their foreheads, their knees. When you see it over a soft area, like the cheek or the thigh or the calf, consider the possibility of child abuse. Now, there are some specific sort of patterns that you should be aware of. Slapping or fingers, certainly a biting pattern, or from a cord or from a cane. Be aware and look out for those. Sometimes you'll come across bruising and you're not sure whether it could be potentially child abuse or not, whether there's a medical cause for it. If there's any suspicion, take a full blood count and coags. Now, those sort of medical conditions or mimics are things like Mongolian spots, erythema multiforme, or things like Henoch-Schönlein purpura, and of course anything that drops your platelets, thrombocytopenia, or a cause for a coagulopathy will cause potentially bruising or easy bruising. Now, we used to look at these charts of bruises to know, how we could say how old the bruise was. That's sort of gone out of favour. So at the moment, I would say if you see a bruise is yellow, you know it's greater than 18 hours old, and just leave it at that. Oh, and make sure that you document really well all the bruises that you find. Next, a few words about burns. This makes up about 15% of child abuse cases. As a general statement, if you see burns in a child under the age of 2 years, it's highly suggestive of abuse. Now, how about some specific burns we should be aware of? Well, cigarette burns, they're deep, they're defined, and they often scar. It's said that you can mix it up with impetigo, but really that yellow crust that easily washes off of impetigo shouldn't be confused. What about hot water burns? Well, if a child's been immersed in hot water, say in a bath, what happens is that they get well delineated water line, and it's usually symmetrical. If it was an accident, you might see irregular edges, splash edges like that, and it's asymmetrical. And of course, if a toddler pulls hot water towards it off a stove, it'll go on the face and the chest and the arms. Be aware also that if you see a burn that has a mark to it that fits a shape, such as from an iron. So always be aware of the potential of burns presenting to the emergency department that are non-accidental. You are the child's advocate. So remember, suspect, assess, and document all these injuries. If you're in doubt, discuss it with a senior medical colleague, with your emergency staff specialist, with the pediatric registrar, with the pediatrician, with a social worker. You are legally obliged to notify docs of any suspected case of child abuse. And most importantly, remember that your intervention can make a big difference in a child's life. Okay, that's enough for child abuse in one coffee. I'll see you next time. Cheers.